I hope that people take away that there's a huge amount of hope right now for both providers and patients, that we have had unprecedented drug approval in recent years in really all spaces, and the whole field has really transformed as a result.
In this episode, Cancer Network spoke with breast oncologist Heather McArthur of the Harold C. Simmons Comprehensive Cancer Center, Erika Hamilton of the Sarah Cannon Research Institute, Hope Rugo of City of Hope, and Paolo Tarantino of Dana-Farber Institute about advances in breast cancer based on presentations they gave at the 25th Annual International Congress on the Future of Breast Cancer East in New York City.
We outlined a number of ongoing studies, particularly studies that are combining immune therapy with a promising new category of drug, antibody-drug conjugates. So we talked about studies that are ongoing, looking at patients who have high-risk residual disease after neoadjuvant therapy being randomized to the current standard of care, which is adjuvant immune therapy alone versus immune therapy with one of these novel promising antibody-drug conjugates. And then there are studies that are moving even earlier in the course of disease, looking at antibody-drug conjugates with immune therapy, going head-to-head against the FDA-approved KEYNOTE-522 regimen or part of the KEYNOTE-522 regimen. Well, adjuvant CDK4/6 inhibitors have become a cornerstone of treatment for high-risk hormone receptor positive disease, particularly those patients who have received prior chemotherapy. It will be challenging if the ongoing immune therapy, if the anticipated immune therapy results from KEYNOTE-756, which demonstrated an 8.5% improvement in neoadjuvant therapy with the addition of pembrolizumab, if that translates into an event-free survival benefit and becomes another standard of care. And the reason why that is complicated is that we cannot co-administer CDK4/6 inhibitors together with immune therapy because of risk for lung and liver toxicity. So that is a potential clinical challenge that we'll be facing in the not too distant future. Most eminently, I'm most excited about combination strategies with antibody-drug conjugates together with immune therapy for the treatment of triple-negative disease, both in the neoadjuvant setting and in the high-risk residual disease setting. I'm also really excited about so-called de-escalation strategies. So patients who achieve a complete response to neoadjuvant therapy, can they forego any additional therapy? Do they need to complete a year of therapy? So I'm excited about those strategies as well. And in the HER2 positive space, we're also seeing a lot of excitement around antibody-drug conjugate strategies. So those successes from the metastatic setting have also moved into the curative intent setting. So I think there will be a big antibody-drug conjugate story there. And I would also advocate for further exploration of immune therapy for HER2 positive disease as well. In the hormone receptor positive space, there are a lot of exciting drugs that are in development, a lot of exciting oral SERDs, oral serine-SERD combination strategy, oral medications. There's a lot going on in that space, and it will be nice to have more oral options for our high-risk patients so that maybe they can forego chemotherapy as well.
Divided this talk into the three different types of breast cancer: ER positive disease, triple negative, and HER2 positive. So in the ER positive realm, we saw new data from an oral PROTAC at ASCO 25 this year. So vepdegestrant beating fulvestrant in patients with ESR1 mutations, and then also touching on the antibody drug conjugates for more refractory patients. In HER2 positive disease, we have a couple of exciting things. We've recently seen data from Destiny Breast 09. Again, this was at ASCO, moving trastuzumab deruxtecan up into the first line. So we anticipate a label expansion coming for that. And then one of the newer drugs I'm highlighting is zanidatamab, which is a biparatropic HER2 antibody. And this is in a large registrational phase 3 trial right now in breast cancer. And then in terms of triple negative, I think antibody drug conjugates are still the story. There are many new ones coming. One of the newer ones with recent data in May of 2025 at ESMO Breast was Emily, or Imiltatug ledadotin, which is a novel antibody drug conjugate that has a new payload, but also a new target. So it's a B7H4 with a novel auristatin payload. What was particularly significant about this trial was that almost everyone had already seen sacituzumab govitecan, and quite a few patients had already seen trastuzumab deruxtecan. So it was very exciting to see the activity of ADC after ADC. T-DXd is a very interesting drug because not only do we have approval in HER2 positive disease, we now have approval in HER2 low and have seen data, in fact, in even ultra low, so the IHC zeros with some staining. So this is really a drug that's getting used, I would say, in the majority of patients with metastatic disease. We also have emerging data that's going to be coming from DB11, which is looking at trastuzumab deruxtecan in the neoadjuvant space in HER2 positive disease. So anticipate more data from this compound. Datopotamab deruxtecan, on the other hand, isn't a HER2 targeting antibody drug conjugate. It targets TROP2. And so this is our second TROP2 targeting antibody drug conjugate to join sacituzumab govitecan. If I had to leave people with one pearl, it would be to not think about all the antibody drug conjugates as a class. Despite the fact that both of these are TROP2 targeting antibody drug conjugates, the side effects are very different. So with sacituzumab govitecan, we really worry about diarrhea and low white blood cell count. And with datopotamab deruxtecan, we worry more about nausea and mucositis, oral stomatitis. The biggest unmet need in the HR positive space is really predicting who's going to continue to get benefit from endocrine therapies and who isn't. We have ESR1, which helps us pick some patients that may be appropriate for things like a vepdegestrant or an elacestrant. And then we have some approval for other regimens, such as post-Monarch, which is fulvestrant with abemaciclib. We have some imlunestrant data that's emerging with or without abemaciclib, although not FDA approved yet either. But really predicting who these patients are that should go on to continue to get endocrine therapy and minimize those patients that are on the top of the curve that aren't getting benefit. In terms of triple negative disease, I think the biggest challenge is really around sequencing the antibody drug conjugates and mechanisms of resistance. That's a quickly moving field. And again, I think we're going to do well when we start to look at both novel targets and novel payloads. And then in terms of HER2 positive disease, DB09 was definitely fantastic data showing benefit of trastuzumab deruxtecan in the first line space with PFS improved by more than a year. The challenge is going to be for those patients that really do well, have very deep responses, maybe have CRs. Are we going to continue trastuzumab deruxtecan indefinitely in that space to 3 or 4 years, or are we really looking for a maintenance time regimen?
Well, I think it's been a huge advance that we've been very excited to see moving CDK4/6 inhibitors into the early stage setting. They are the best tolerated targeted agents that we have, although there are side effects that patients have, and we have to consider use of these agents very carefully because we're adding both side effects as well as cost and additional time because patients have to come in to get blood tests, monitoring, and also need more frequent clinic visits. There's all sorts of things that you have to take into account when you're adding more therapy. So I think the biggest question we have is, one, what's the benefit? And we've already seen that there is not only a reduction in the rate of recurrence, but the rate of distant recurrence, which is our, of course, key goal as oncologists, and that's what the patients are really focused on, of course, as well. But then we've seen that there's a carryover effect, which I think is so incredibly exciting, because what you see is that not only are you reducing the risk of recurrence while you're taking the drug, but that even 3 years after stopping the drug, you're seeing a significant drop in the number of patients with distant metastases from the 5-year data from the Monarch E trial. And we've seen carryover of data with the ribociclib trial as well, with a slightly shorter follow-up time period. But we're also seeing that suggestion of an increasing benefit over time. So it's interesting. It's not just a carryover effect, but it's actually that by taking the drug here, early, you're actually having a bigger effect later on the risk of distant recurrence. And we know the risk goes out to 20 years plus for patients with hormone receptor positive disease. So we need more time, more follow-up, and additional biomarkers to help us understand the optimal duration. One drug given for 2 years, one drug given for 3 years. We don't really know what the optimal duration is. We're just going to need longer term follow-up to see, is there a time when the effect seems to wane? We're seeing less patients living with metastatic disease, although we're waiting for the survival data, but we're hoping to see survival data from Monarch E within the next less than a year. And I think that's also is certainly highly anticipated data. So what do we do in the clinic? I think it's really clear that patients with high-risk disease, multiple nodes, high risk, 1 to 3 positive nodes with other high risk features. Those are patients where we're frustrated with the lack of ability to give the best therapy. We give everything that's part of guidelines and treatment, and we see unacceptable rates of recurrence. So these patients are offered CDK4/6 inhibitors. How we decide which one, again, is independent. And, you have to really decide with the patient on what the right treatment is for them, taking into account the side effect profile, the duration of therapy, and the length of efficacy data that's available. And then I think the big question comes up for us is which patients with node negative disease should be treated. And, we're using the Natalie criteria at the moment, but judiciously. A patient who's a lot older, who has other comorbidities that may impact the treatment, or who has a huge share of cost in our current environment in the US, it may not be the right balance at the moment. We need a little bit longer follow-up data. So it's a very exciting area. We talk a lot to patients about this. I have to say, it's an ongoing conversation, because I'll tell patients at the beginning of neoadjuvant therapy, when I get to they're finishing radiation and I'm bringing it up for the 10th time, it's a surprise. So I think they just, it's something we have to keep talking about with our patients, because they really like a neat package of beginning and end of treatment. And we're extending out sort of the targeted therapy, not just the endocrine therapy. So that's important for our patients.
We're realizing that having more treatments approved is an important opportunity for our patients, and we do need more treatments, because these patients cycle toward different lines of therapy, and after progression, we really want to have options. At the same time, we're realizing that sequencing these agents can come with some degree of cross-resistance. We conducted a large study with about 800 patients in Flatiron, and we found that there definitely is cross-resistance between T-DXd and sacituzumab govitecan, with SASI used after T-DXd leading to a PFS of about 3 months, whereas traditional chemos can lead up to 4 to 5 months. So in truth, we still don't have prospective data clarifying the role of sequencing, but in the absence of that, I usually tend to do what I call the sandwich strategy, meaning that I try to switch mechanism of action of my treatment after a topo-1 ADC. Imagine after T-DXd, I consider using maybe a taxane or capecitabine before going back to another topo-1 ADC. And so in truth, I think moving forward, we need to clarify this, and we have several prospective trials looking at this. The Trade-DXd randomized trial, the Satine trial, the series, many prospective trials, and I think we'll start to see data from the end of this year, probably also next year, which will clarify the role of sequencing of ADCs. So we're realizing that ADCs are, of course, extremely active, but combinations with the right drugs can make them even more active and effective. And the first 2 phase 3 trials with ADC combinations that showed a major benefit are the DESTINY-Breast09 trial that looked at first-line T-DXd pertuzumab with extremely long PFS, 40 months median PFS, which is definitely practice-changing, and then also ASCENT-04 with first-line sacituzumab govitecan pembrolizumab for the first-line treatment of metastatic triple-negative breast cancer with PD-L1 positivity, also reaching a very long PFS for the type of disease of 11 months plus. So in truth, we're realizing that adding another agent with a different toxicity profile can be beneficial, but still combinations always can increase toxicity. So it's important to be mindful, to be rational, to find the right combinations. And in the future, I think we're gonna even start to try combining ADCs. They already did it for urothelial cancer, combining enfortumab vedotin sacituzumab govitecan with very high efficacy, but also with toxicity. And I think we'll need to modulate the dose of ADCs in order to maximize their benefit, and in the future, probably combining them, just like we combine anthracyclines with cyclophosphamide, carbo with paclitaxel, etc. So it's a brave new world ahead, and we're just at the beginning of it.